essays?
Did anybody else lose Kristen?
Yeah.
I did.
Yeah.
Okay.
Was she on and then dropped off?
Yeah.
Yes.
Yeah, we don't
Yes.
hear her anymore.
Okay.
Hi, everyone. Sorry about
you.
that. I honestly don't know what happened. Something just clicked off. So I apologize for that, but I don't know what happened. But I am now back. So I will welcome you all again. My name is Kristen Mari and I chair the master's program. And today we have a new group of master's students who are going to be each making a 10-minute presentation followed by 5 minutes of Q&A. And before we begin, I just want to thank all of you, family and friends who are joining us. And especially I want to give a shout out to all of you who have been readers and advisors for these students. There's been a lot of background work behind these essays and presentations. So I really want to thank you all. And finally, a really big shout out to Kristen McCormick, who has helped with facilitating all of the logistics behind this. So without further ado, and hopefully my computer will not give out on me anymore, I'm going to welcome Nikita Patlolla to the virtual platform. We're going to have Nikita go first, so because of scheduling issues. So Nikita comes to us from the University of Delaware, and she has received 2 different bachelor's degrees, a BS in neuroscience and a Bachelor of Arts in Biological Sciences. So Nikita, whenever you are ready, you can feel free to share your screen. The title of her presentation is Perceived Barriers to Postpartum Weight Loss, a Scoping Review and Lived Experiences of Participants in the Healthy for Too Healthy for You study.
Kristen, thank you so much for that wonderful introduction. I just want to make sure, are you guys seeing just my PowerPoint?
Yep.
Okay, great. Thank you again. Good afternoon, everyone. So good to see everyone here. Yes, so my presentation is on the perceived barriers to postpartum weight loss. And just to give a little bit of background before we get into my research, the pregnancy and postpartum time periods are very critical periods, and they play a vital role in both the short-term and chronic health of mother and child. And gestational weight gain, or the weight gain during pregnancy, acts as a modifier in maternal and fetal health. So some gestational weight gain is necessary and it's essential. However, excessive gestational weight gain and subsequent postpartum weight retention is a significant risk factor for developing obesity and cardiometabolic health conditions later in life. There's been a significant amount of research during the pregnancy period because we find that it provides women with a really unique window of opportunity to take advantage of this period to develop healthy habits and lifestyle patterns. And women are shown to be more motivated and malleable in regards to their current behaviors during this time period. However, because the effects of gestational weight gain last far beyond the pregnancy period, many studies are now focusing on the postpartum period to target that chronic nature of gestational weight gain. So the postpartum period is defined as a moment from birth to about 12 months after delivery. And we find that this is an extremely vulnerable period. It presents, it's mentally, physically, and emotionally challenging. So it prevents significant challenges with either developing or continuing healthy behaviors and habits. And in addition, there are significant systematic and programmatic and legislative barriers that disengage women from prioritizing their own healthcare. So to accurately and effectively inform policy and program recommendations, it's important to understand the perspective of the mother about her own perceived barriers to weight loss. So first, I conducted a scoping review of the exhaustive qualitative literature to provide a comprehensive synthesis on the mother's perceived barriers to postpartum weight loss. Then I interviewed participants of the Healthy for Two, Healthy for You study to see if the lived experiences of women in this cohort parallel the concepts synthesized in the review. And then I used the existing socio-ecological framework to integrate my conceptual findings to inform future program and policy recommendations. So my review was done using 3 databases, and I included postpartum qualitative data up to 5 years. And I excluded postpartum qualitative data beyond 5 years and any data from the pregnancy period. A critical appraisal was conducted using the JBI checklist for qualitative research. The participant interviews were conducted from the Healthy for Two, Healthy for You study. This is a pragmatic randomized controlled trial within the Johns Hopkins prenatal care practices. And when participants are randomized to the intervention group, they are integrated with an evidence-based pregnancy and postpartum health coach as a part of their pregnancy care. In addition, they also have access to web-based learning platforms and are tracking their weight and diet and having weekly conversations with a health coach in an effort to limit gestational weight gain and prevent obesity. And I use the socio-ecological framework because it has been known to be used quite often in postpartum research. So out of the 833 studies that were imported for screening, 24 were included in the final review, and 9 of these studies focused on low-income urban populations. So the table on the right shows the 5 most commonly identified barriers across the studies. So first, lack of time was by far the most common, and women said that most of the available time during the day was, of course, prioritized to infant and other family needs. So prioritizing their own exercise and diet was just not possible. Second, I found that a lot of women were speaking to the lack of confidence they had in their abilities to achieve or even start their postpartum goals. And one interesting thing was that the role of social media was actually consistent throughout a lot of the studies and throughout all different income groups. But with low-income women, of course, much of the lack of self-efficacy had to do with not having access to walkable neighborhoods, access to gyms, or access to affordable groceries. Childcare was also a significant barrier, and this was a spectrum. Some women just did not have access to afford childcare, and some women also felt that the expectations of the mothers were to be the primary caregiver for their children, so they didn't really think to ask for childcare. Lack of knowledge was a significant barrier, and this was interesting because across the studies, across income groups, many women spoke about the lack of information given to them by their providers. And they actually had the significant and dramatic shift as soon as they delivered, where a lot of the attention was given to the baby and taken away from the mother. So while women were generally agreeable about the importance of healthy eating and exercise, they felt that they lacked really vital information, like what types of exercise to do during that immediate postpartum period, what types of food to eat, how much of different types of food to eat. So again, this contributed to the lack of self-efficacy because they felt they lacked the knowledge in their abilities. In addition, lack of support from partner was common, and this was also on a spectrum. Some women just did not have a partner, so they had no support, and some women felt that the roles of motherhood were just so overwhelming that even if their partner tried to help, it wasn't doing enough. Women also cited loneliness and changing identity as a potential reason for being unsupported. And when it comes to the interviews, out of 35 intervention participants as of March 1st, 2022, 2 interviews with postpartum women were conducted. It's important to note that these participants were privately insured, they received a degree from a higher educational institution, were homeowners, and lived with their partners, who are the fathers of their children. So they are not representative of the demographic makeup of the Healthy for Two study. For the most part, the findings did parallel the concepts from the review. They shared that lack of time was a significant barrier and that there were many other things that they needed to tend to on a daily basis, so putting themselves kind of last. And they also paralleled that they received almost little to no information from their providers about postpartum lifestyle. Most of the information came from the program and came from the web-based learning platform and the conversations with their health coaches. When asked about the role of the intervention in their postpartum weight goals, they said that the one-on-one coaching model was the biggest motivator to them. If they weren't motivated to do it for themselves, they were motivated because they had someone to hold them accountable every week. And so from the very beginning of reading these articles and going through the review, it was apparent that the socio-ecological framework was very commonly used amongst postpartum researchers to describe both motivators and barriers to postpartum healthy behaviors. So I also wanted to use this framework to integrate that because I think it tells us where program and policy initiatives need to take place. So economic constraints influence childcare, access to food, walkable communities, and thus increase anxiety and perceived stressors. And on an institutional level, there was agreement that the deprioritization of women from the health sector influenced not only the amount of knowledge they received, but also the types of information they received, and also their own attitudes towards the importance of weight loss. Combining all of this with the deeply ingrained social norms of motherhood and associated responsibilities, it enhances women's feelings of solitude and fatigue and stress, and also the expectation that women should set aside their own health to prioritize the health of babies and other family members. So the lifestyle and behavioral choices that postpartum women make exist within the context of the factors surrounding them. So it's important to use a framework like this when determining points of intervention among postpartum women. So where can we intervene? On a policy perspective, I think it's necessary to consider the role of Medicaid and expansion efforts regarding postpartum coverage. Currently, Medicaid finances 40% of US births, so a large chunk of US births, and currently under federal regulations, falling below the 138% of the federal poverty level assures that women are covered up until the 60th day postpartum. On the 61st day, parental coverage eligibility becomes a much more complicated issue, and depending on the state, it varies drastically. The ACA's expansion initiative expanded coverage past the 61st day. However, 12 states as of today have chosen not to expand coverage. So for example, new mothers in Texas lose their coverage on the 61st day, unless they fall between less than 17% of the federal poverty level, which is about $3,600 for a family of three. And the postpartum effects of this coverage gap is more significant in non-expansion states, which is troubling considering that 55% of maternal deaths occur beyond the 60th day. And it's also important to note that the populations that are disproportionately affected by this coverage gap are Black, Indigenous, and Hispanic Spanish-speaking populations. And the leading voices in many reproductive and maternal health organizations advocate for expansion of coverage for at least 1 year postpartum. In terms of program recommendations, the interviews showed that the one-on-one coaching model works. It increases motivation and enforces accountability. And because a lack of time and social support were listed as some of the most common barriers, programs and interventions need to take that extra step to recruit family members as a part of the program design to facilitate participation and social support. And another idea is to continue to increase the use of web-based platforms to deliver health information and coaching so that women are more inclined to utilize these types of services when it's most convenient for them. So in conclusion, in order for these recommendations to actually develop into sustainable interventions, there is a significant need for a multi-sectorial collaboration of healthcare professionals, social support systems, and evidence-based legislative efforts. Thank you so much. And I would like to give a huge thank you to these people, my family and friends, Dr. Wendy Bennett and the entire Healthy for Two team, Dr. David Page, and a special thanks to Josephine Pites and the rest of my cohort. Any questions?
Great job, Nikita. Wonderful. So I will take questions, and right away, I see Jess, you have your hand raised, so you can go ahead and ask your question.
Sorry, that was supposed to be a clap.
Oh, sorry. Okay, no question.
Yep.
Okay. Mona, you have your hand raised?
Yes, hello. First of all, can I just congratulate Nikita, because I saw you like last week and I'm so proud of you. I love it. One question that I had, and I think this was sort of connected even when I was doing my own interviews, was, what were some challenges, or were there any challenges associated with interviewing participants?
Yes, thank you, Anna, for that question. There were significant challenges with interviewing participants. Initially, I had wanted to interview many more participants, but as I was recruiting them, a lot of the women in the intervention group ended up having complex deliveries. So they obviously didn't reach back out about the interviews. And then in that 3 to 4 week period, a couple of them had come down with COVID and pushed their interviews back and ended up canceling the interview. So life pops up, things happen. So I ended up not reaching back out to those participants just to respect the time that they were going through. But yes, thank you.
Great. Ishita.
Great job, Nikita. I have a question as well, actually connected to a healthcare class that we're taking together. So you mentioned both policy and program recommendations. So I'm just wondering, like, what role you think clinicians or providers play in both preventing the excessive gestational weight gain and also losing weight postpartum.
Yeah, thank you so much, Ishita. What a great question. I think providers have a really fundamental and crucial role in not only the way that they approach gestational weight gain, but also weight management in general. People tend to trust their doctors, but I think people that have concerns about their weight management tend to trust their doctors a lot less, which is concerning because the first and only point of contact that like 99% of the people have with the health sector is through their providers. So the role is really important. And I think that there's been a lot of research lately that into the psychosocial aspect of weight management, and more research now has been shown that rather than simply focusing on numbers and scale measurements and BMI, focusing on health behaviors and engagement with sustainable healthy patterns has been shown to have as great or even greater effect on long-term chronic health. So I think many people are driven away from conversations about their health because of bad experiences with providers. So I think the first step for clinicians is to really shift the way that these conversations are had. And I think really, if you think about it on a life course model, these conversations should be had well before pregnancy, probably when they're children. So reframing the way conversations are had and to emphasize the role of healthy behaviors and lifestyle patterns rather than having such a militant focus on numbers, I think is the best way.
Great. And we have time for one more question. And I see that Haley has asked, what was the reasoning for the inclusion of women up to 5 years postpartum?
Yeah, so the reason that I included participants up to 5 years postpartum is because that's what's done in the research a lot. 5 years is chosen because the postpartum experiences of women are recent enough to be adequately recalled, but past the period of constant infant care. So it's been extensively used in the literature. So I stuck with that 5 year period time.
Great. Okay, Nikita, wonderful job again. Thank you so much. So our next presenter is Amna Baloul, and Amna graduated from the College of William and Mary, and she earned a Bachelor of Science in Kinesiology, Health Sciences with a concentration of Public Health. And so the title of her presentation is Women's Empowerment as a Pathway to Improving Maternal Health in Sub-Saharan Africa. So welcome, Amna.
Thank you so much, Dr. Mowry. Can everyone hear me okay?
Yep, you're great.
Awesome. So good afternoon, everyone, and welcome to my thesis presentation on women's empowerment as a pathway to improving maternal health in Sub-Saharan Africa. Globally, the association between women's empowerment and maternal health has received an increasing level of attention. This is especially of interest in Sub-Saharan Africa, also known as SSA, as the region accounts for about 66% of the global estimate for maternal mortality. Across the region, women are more likely to lack agency in decision-making within the household, which can impact family planning, access to education, employment, and beyond. And these factors have been cited as critical determinants to maternal health-seeking behavior and ultimately maternal health. So the objectives of this review are to present key information on the association between women's empowerment and maternal health in Sub-Saharan Africa through a scoping review, and to analyze results through the theory of gender and power, also known as the TGP, and highlight gaps in knowledge within existing literature. And to really simplify things, the key question here is, based on recent literature, how convincing is it that women's empowerment is an effective method to improve maternal health in Sub-Saharan Africa? So I'd like to first define some key terms, beginning with women's empowerment. While many definitions of the term exist, it's widely defined as a process in which women who have previously been disempowered develop the ability to make life-enhancing decisions, and increase their self-efficacy. Self-efficacy refers to the belief in an individual's ability to carry out a given task or goal. Another definition describes the term as a multidimensional process that ranges from women understanding why they are suppressed to collectively acting towards social change. And I've included both definitions here to highlight how individual and collective agency are essential when defining women's empowerment. The next key term is the theory of gender and power. This theory posits that there are three main social structures responsible for the gender dynamics and relationships between a man and woman. The sexual division of labor, which refers to the gender-based nature of occupations, which often grant men higher status, influence, and participation in the workplace than women. The sexual division of power, which alludes to the imbalance in influence and authority between heterosexual partners. And the structure of cathaxis, which refers to the internalized social norms surrounding a woman's sexual and reproductive behavior. This structure is often examined in the context of marriage. Moving on to my research methods, the first step of my review was to define a clear topic of focus, which I've outlined in the objectives of this presentation. The second step was to develop a research protocol, which was establishing my inclusion and exclusion criteria. Inclusion criteria for the studies in the review were that they were written in English, peer-reviewed, written between 2000 to 2022, and addressed women's empowerment in sub-Saharan Africa and its association with maternal health. Exclusion criteria were studies not published in English, not peer-reviewed, written outside of 2000 to 2022, and that do not address women's empowerment in sub-Saharan Africa in relation to its association with maternal health. The third step was to carry out a database search. All literature was identified through PubMed, and three search terms were used: empowerment, maternal health, and sub-Saharan Africa. I also combined methods such as truncation, Boolean operators, synonyms, etc., to optimize search results. So following the database search, I screened literature based on my inclusion and exclusion criteria. I then thoroughly read through the literature that met inclusion criteria and extracted relevant information onto a data extraction template that I'll present in the next slide. And finally, I synthesized evidence from the included literature and presented it in this review. So as I mentioned, here's a snapshot of the data extraction template I developed to chart relevant information for this review. And I want to draw your attention to the categories I included in the template, which include study design, as well as the theory of gender and power and dimensions of empowerment addressed. As an overview of my key findings, 12 peer-reviewed journal articles and 2 reports were included in this scoping review. Study locations represented range from Ethiopia, Guinea, Mali, to Nigeria, Senegal, Tanzania, and sub-Saharan Africa broadly. The study designs used range from cross-sectional, ecological, and longitudinal to literature reviews and mixed methods. Findings from this review were categorized into 2 levels of organization: the 3 divisions of the theory of gender and power, and 3 dimensions of empowerment: political, economic, and sociocultural. And these 3 dimensions were chosen due to the breadth of information available on them in the studies within this review. Starting off with key findings from studies that addressed women's political representation in sub-Saharan Africa, these were categorized under the sexual divisions of labor and power and the political dimension of empowerment. The main finding here was that several studies revealed when more women have political power, they're not only more likely to contribute to funding for maternal health services, but also to the health and social welfare of countries in sub-Saharan Africa. The theoretical applications here are that restrictions on political representation of women in sub-Saharan Africa are conditions perpetuated by the sexual divisions of labor and power. And thus, when women are given the opportunity to be in political leadership positions, they may contribute to improvements in maternal health. The key findings from studies that addressed women's employment status and control over earnings were categorized under the sexual divisions of labor and the economic dimension of empowerment. Main findings here are that in households where women earn a higher income than their partners, their maternal health seeking behavior may not always improve, and this was revealed by a study in Nigeria. Similarly, a study carried out in Ethiopia revealed that women with employed husbands had a higher likelihood of being highly autonomous in comparison to women with unemployed partners. The theoretical applications here is that financial dependency on male figures, which is a common outcome of the sexual division of labor, has been repeatedly identified as a contributing factor to structural inequities in the region, which give rise to low levels of women's empowerment. Key findings from the studies that address women's educational attainment were categorized under the sexual division of power and the sociocultural dimension of empowerment. The main findings here are that across sub-Saharan Africa, research findings generally demonstrate a trend of strong positive associations between women's educational attainment and the use of modern contraception, antenatal care, and skilled birth attendants. However, there are exceptions to this. One study found that while women's formal education had a positive and direct association with SBA use in Tanzania, this was not the case in Senegal. The education of male partners in sub-Saharan Africa is also associated with improvements in contraceptive use among their female partners. Applications to the theory here are that from the lens of the sexual division of power, the heightened sense of self-confidence often developed through education can offset power imbalances between a woman and her partner in the household and accord her greater influence in family planning, for example. Finally, key findings from studies that addressed marital age and family planning in sub-Saharan Africa were categorized under cathaxis and sociocultural empowerment. The main findings here are that a study identified a positive association with the progressive perception of older age at first marriage and SBA use in Senegal, but not in Tanzania. And women's empowerment by means of promoting older age at first marriage may not always lead to improvements in maternal health if, at the structural level, health systems are corrupt and unsuitable for a population of healthier mothers. Theoretical applications here are that women who are empowered to reverse the cultural norms of early marriage and challenge cathaxis may be more likely to carry out more informed health decisions for pregnancy care. The findings from this review revealed gaps in research and that several considerations should be made towards how a male partner's earnings can impact women's empowerment and maternal health-seeking behavior, the measurement of other means of informal knowledge sharing that exist across sub-Saharan Africa beyond the typical Western definition of formal education, and finally, policies targeted towards increasing marital age to improve maternal health outcomes should lead with the objective of promoting a woman's choice rather than enforcing Western biases of marital age. And of course, there were some limitations to this review. And some of these were that only one database was used, which was PubMed. The subjective nature involved with selecting which theoretical division was categorized under each finding. These divisions are so interconnected that they could arguably be used to analyze every dimension of empowerment. And finally, an individualist Western lens is often used in studies to define and measure women's empowerment in sub-Saharan Africa, which doesn't adequately account for cultural differences in defining empowerment. So returning back to our key question, how convincing is it that women's empowerment is an effective method to improve maternal health in sub-Saharan Africa? The evidence is partially convincing because the findings are mixed. Women's empowerment in one dimension does not always bring forth empowerment in maternal health-seeking behavior and outcomes. Key findings underscore the importance of being culturally sensitive when defining and measuring women's empowerment in future studies. With that, I'd like to extend my deepest gratitude to my readers, Dr. Shannon Wood and Dr. Pamela Donahue, who's also my advisor, to Kristen McCormick, Dr. Mowry, and Dr. Gross, my cohort members, as well as my family and friends. And with that, here are my questions. Thank you, everyone.
Thank you so much, Amna. That was really interesting.
Thank you.
So again, I will open up to questions, and right away I see Grace's hand. So Grace, you get the floor.
Amna, yes, thank you, Amna. That was great. I'm so proud of you. Great findings, great presentation. So yeah, those are great findings. I just had a question. What was the most challenging part of developing this scoping review?
That's a really great question. Thank you, Grace. So I feel like I came into this research process thinking it would be really organized, very structured, but I soon learned how messy research can really be, and I have a lot of respect for people who do this as a full-time job, because there were so many moments and times where I realized, oh, I need to add something. I need to add another chart, for example, to my methods to make sure that I'm explaining my results thoroughly. And so I would go back, create another chart. And it was a very non-linear process. And I think that was the most challenging part for sure. But I came out of it with a lot of respect for sure for people who do this full time, and then also with a much stronger understanding of what it's like to do a scoping review and all of the steps behind it.
Great. Thank you so much. So other questions? Feel free to use the chat, or you can go ahead and raise your hand. Maybe while we're waiting, Amna, I just wanted to know if you could clarify or just explain a little bit more what you mean by, the fact that we need to have more or consider non-Western informal knowledge gathering. So can you just tell me what you mean by that and what needs to happen with that?
Absolutely. So interestingly, oftentimes when women's educational attainment is studied in relation to like improvements or the association with maternal health seeking behavior, they're looking at what the West would define as like formal education, right? Sitting down, high school classes, middle school, like that, those kinds of formal environments of education. But there are also other informal environments of education and training that go on within sub-Saharan Africa, whether that's like training programs for jobs, kind of like academies, also religious schools, things like that of that nature are still considered education there. And so I think it's really important to factor that in, that those cultural considerations in when defining what education looks like in sub-Saharan Africa.
Gotcha. Okay, thank you. That's helpful. Terry, I see your hand up.
Thank you. Hey, Amna.
Hello, Dr. Powell. So nice to see you.
So good to see you. I'm sad we didn't see each other more. Darn COVID. So you noted as a limitation that you only looked at PubMed. And so I was wondering if you could say more about that, because I feel like a lot of Scopus would have been a really good web database also to look in for this topic in particular.
Yeah, thank you so much for that question. So the reason why I looked at PubMed in particular was I met with a research librarian through the Welsh Library, and she took me through how to use PubMed, and then she also took me through how to use Embase. And we really thoroughly looked at PubMed, and I felt very confident in terms of the advanced words, the advanced like search techniques through PubMed. So that's particularly why I use PubMed. But I think if I did this again, I would expand the amount of databases that I use to really optimize my search results and more thoroughly examine the question.
Great. You somewhat just answered Mona's question too, but maybe just if there's anything else. She asked, what was the most challenging part of developing the scoping review?
Oh, that's a great question. I think the most challenging part was making sure that I hit every single, first of all, I had to look up what the definition of a scoping review was, because I was familiar with literature reviews in general, but I think making sure that I hit every single step of what a scoping review entails was probably the most challenging part, because that did require me to kind of backtrack and make sure I was as thorough as possible.
Mm-hmm. Great. Well, thank you so much again, Amna. That was
Thank
really
you, everyone.
Okay, next up, our third presenter is Sarah Clifford, and she graduated from Barrett, the Honors College at Arizona State University with a Bachelor of Arts in Global Health. And the title of her presentation is Communication Strategies for the Title V Maternal and Child Health Block Grant, a Case Study. So Sarah, you are welcome to the virtual platform.
Thank you. Can you guys see, are you seeing presenter mode or?
Yep, you're good.
Okay, perfect. All right. Hi, everyone. I'm very excited to present today. And I'm going to be presenting on communication strategies of an unnamed state health department where I was able to conduct this research. So to start, I want to give you some background on what the Title V Maternal and Child Health Block Grant is. Title V is a federal state partnership that exists across 59 US states and jurisdictions and has been around since 1935. Title V funds are allotted by HRSA, and then they are matched by a designated state Title V agency, which is often a Department of Health. And in 2019, Title V made more than $6 billion in funds available for MCH programs at state and local levels. Title V also provides MCH essential services to over 60 million pregnant people, parents, infants, children, and youth annually, including children and youth with special health needs and their families. And Title V's block grant format allows states flexibility to address their unique priorities, but each Title V agency across the country uses the same needs assessment and action plan process to identify and target priorities and then report annually on that progress. And all of these activities are intended to be family-centered, community-based, and culturally competent. And I know that is a lot of information that doesn't tell you exactly what Title V is doing on a daily basis. So if you look to the left, you can see there are some examples of the type of services Title V provides. And these are split into 3 sections: direct services, so things like home visiting for pregnant and postpartum families; enabling services might be case management for childhood lead poisoning or care coordination for children with special health needs. And then finally, there's public health services and systems, and the bulk of Title V's work is taking place in that bottom part of the pyramid. And that is dedicated to what we know as the 10 essential public health services. So for example, the maternal mortality and morbidity review process, or birth defects research and injury prevention training. And again, these activities do vary a lot by state because, as I mentioned, they're each going through a process of identifying their priorities and then tailoring them accordingly. So I want to give you a sense of what current communications look like for Title V. And as you can see, there's a lot of variation to the way states are communicating. There's the HRSA website, which you can see in the top left, and that provides national and state snapshots and data relevant to Title V. But a lot of that information is more useful to the states themselves than external stakeholders. And most states do have websites where you can find some general information on Title V or fact sheets, but many are not tailored to specific audiences, and they might just include very basic facts about Title V. So that variation across agencies' communication strategies led to the question, how should we be communicating about Title V? There's little available guidance on best practices to really communicating the purpose and the impact of Title V, but there is this identified need to engage and communicate with relevant stakeholders because that's really important to making sure that throughout the needs assessment and action plan, we can identify the correct priorities for that population. So that knowledge gap led us to our case study, which intended to identify the key audience segments for Title V, and then build evidence and insights from relevant stakeholders to inform the development of a strategic communications plan for the state's Title V work. So to accomplish that objective, I conducted a descriptive case study based on qualitative systems analysis of semi-structured key informant discussions at our unnamed state Title V agency. And there were 12 discussions. 11 were formatted as focus groups, and I had 1 interview, and they were held virtually from August through December of 2021. I took field notes, and general trends and agreements on issues were identified in analysis. And most of these discussions were held with internal stakeholders. So a lot of these folks were staff in a role supporting Title V, and they were identified by Title V leadership. 1 focus group was held with the Title V Advisory Committee, which consisted of external stakeholders who came from a variety of backgrounds. So when I was having these discussions, the questions I asked belonged to 4 domains, which were selected given their importance in the existing literature on health communications. So first, this included defining the audience segments. So really, who needs to know about Title V? The second was the purpose, or the why, for communicating. Third was messaging, and those questions tried to capture the core points for an audience to take away from our communication. And finally, delivery questions were related to the modality in which the audience would prefer to receive their message. So first and foremost, what we found was that folks supported segmenting the audience into 3 larger groups. The first group was families, parents, and youth. And these are really the direct recipients of Title V services, so engaging them is really critical. The second audience segment was providers, and this includes providers of both community and clinical programs and services. These are often the partners of Title V, and so they're really important to the work of Title V across the state. And then finally, we have internal Title V agency staff. And although their roles may look different, of course, they are responsible for the administration and oversight of Title V, so they are also really important to communicate with. So in my essay, I went through and I described each of these domains and how they differed by audience. But for the sake of time today, I am just going to simplify that to highlight some of the most important things. For families, folks pointed out that most people really don't know what Title V is. And that was really emphasized by staff who said that explaining funding and reporting and all those things to families is just unnecessary. Instead, they said most importantly, families should understand their role in guiding Title V priorities through their engagement. Stakeholders suggested using things like ongoing feedback surveys or social media to engage families, and using messaging that acknowledges and welcomes a spectrum of engagement and highlights the benefits of participation to the families themselves. Next, we found that for providers, there was a focus on conveying how valuable it is to partner with Title V. And we found messaging should emphasize opportunities for collaboration and highlight what Title V brings to the table, which might be its existing infrastructure, or perhaps its funding or its reach across the state. And for providers, the message may be delivered by fact sheets, which provide more technical data or technical assistance and training. And then for internal staff, many participants highlighted that staff actually don't always understand what Title V is either, or what it has to do with them. In fact, it was mentioned several times that staff who receive part of their salary through Title V might not always realize it. So folks mentioned maybe a need to build more awareness and interconnection internally to avoid kind of creating silos, because Title V's work does occur in different bureaus and departments. So the purpose for communicating with internal staff was identified as helping them to understand the role of Title V funds in their own work. We said that messaging should frame Title V's reporting mechanisms and their funding as a tool for these internal staff and demonstrate how Title V can support their work internally. And also the idea of using maybe things like priority implementation teams internally or priority progress reports were helpful for internal staff so they can kind of understand what's going on across the departments. And then finally, across audience segments, informants highlighted that Title V communication should always use frames to simplify these complex public health concepts and make sure that our message resonates with the audience. Use bidirectional communications to encourage engagement and a two-way relationship. And then use a participatory model to make sure we're emphasizing community-driven approaches. And finally, we want to highlight the utility and the value of partnering with Title V across communications. So there were some limitations. This was limited to one Title V agency, and I had mainly internal staff participants, and these interviews were not recorded, so data could have been lost in the analysis process. However, there are some next steps. Right now, the state is working on developing and testing various communications campaigns, integrating the knowledge of this case study. And then some lessons I learned. I think I learned a lot about how important it is to communicate and effectively engage a range of stakeholders for public health institutions. I think that simply presenting information is not enough, and public health professionals really need to use framing techniques to make sure that we effectively convey critical information and push productive conversations forward among a wide range of stakeholders. And so that takes me to my acknowledgements, and none of this would be possible without your support. So thank you so much to my amazing advisor, Dr. Mari, this department and cohort, my family, my partner, and my dog, Max, of course, and everyone else I've been able to meet over the past 2 years at Hopkins. I've had the time of my life, and I cannot believe it's over.
Gotta love Max too. Thank you so much, Sarah. This was great. So I will take questions for whoever I see first. Feel free to use the chat or raise your hand again. Cynthia.
So great presentation, Sarah. So as someone who thinks a lot about Title V, I was sort of curious about your findings. Is there anything that sort of struck you as being unexpected in terms of the partnering into the three groups or the nuances across the groups?
Yeah, actually, absolutely. And I learned a lot about my assumptions going in, because I kind of assumed it would be most important to communicate with families, just because that's the bulk of the recipients of Title V's work. But what I ended up kind of finding by the end was that I think internal staff are the most important, just because they're so critical to the success. And if they don't fully understand, like, how can we get families to fully understand what Title V is? And so that really surprised me. But I think that was exciting, because a lot of states are currently targeting families with their fact sheets, and maybe that's not the most effective way to do it.
Yeah, it's interesting to also think about whether or not the importance of communicating with staff is more heightened now amid COVID, with so many staff still working remotely or juggling all those things. So maybe it's not the either or, but as you suggested, it's really thinking about different messaging streams for the three groups. So thanks so much. And it was exciting to hear.
Thank you.
David. David, you just have to unmute yourself.
I didn't want to creak and everything during it. Thank you. It was a wonderful presentation, really tackling a oft-forgotten topic. What I wanted to ask you was the political dimension of this is considerable in terms of funding and in terms of sustainability, both on a federal and state level. And I was wondering, with regard to messaging and framing and so on, how did you think about it, and what can we do better to make sure that these funds continue to exist and in an appropriate delivery format?
Yeah, I think that's a great point. You know, something, of course, as I went through this project, I couldn't help but think about COVID and the way we were communicating about COVID to the public and how we saw, you know, so many different responses to that. Something I learned about was, it's called the Frameworks Institute, and I learned about the different ways they have these different frames. They have some great ones for public health too. And it talks about not just telling people what to think, but how to think about it, and making sure that in the way you're describing things to them, even things as simple as like social determinants of health, which we all understand now, you know, that's complicated even for public health professionals, I think. And so changing the way we frame that to make sure people understand how it benefits them, et cetera, and it's less complex, I think that's really important. And it's important for every public health institution and program across the board, I think.
Thank you. Thank you.
Great. Maybe Al can ask one little small question. And I know you were looking at a lot of states. Do you have any particular example that you thought they did a particularly great job in getting their message out?
Yeah, I loved, there's two that I really like. I really liked Louisiana because they made theirs really bi-directional, and at the back of their fact sheet, they have a survey you can send back in. So that's really cool. I thought it's a great way to get people to make sure that they're really engaging. And then the second one I really liked is Minnesota. They use data stories, which I think is a great way to help communicate. And so instead of just listing these facts and numbers, they really use the data to make stories that we can all relate to.
Wonderful. Okay, well, thank you, Sarah, so much. Great job. Okay, our fourth presenter is Emma Koppes, and Emma graduated with a Bachelor of Arts from Clark University with a major in biology. And the title of her presentation is Substance Use and Breastfeeding, a systematic review on cannabis, buprenorphine, and methadone use during breastfeeding. And please forgive me if I got that last chemical wrong. Emma, are you there?
Yes, let me just trying to share my screen.
No worries, take your time. I'm just making sure that I didn't see you, so I see you now, so that's good.
All right. Can everyone see in presenter mode now?
Yep, you're good.
All right. Hi, everyone, and thank you, Dr. Mari, for the introduction. Today, I am going to discuss substance use and breastfeeding, and specifically, my master's essay was a systematic review on cannabis, buprenorphine, and methadone. And yes, buprenorphine is pretty challenging to say. I had to practice multiple times. So here is an overview of what will be discussed today, including background, methods, results, and then discussion. All right, so before I begin, I think it's important to go over some key terms and acronyms. So ABM refers to the Academy of Breastfeeding Medicine, and specifically ABM has a protocol number 21 that goes through recommendations for substance use while breastfeeding. OUD refers to opioid use disorder. MAT refers to medication-assisted treatment, and buprenorphine and methadone are two forms of MAT, and I will use the term MAT to describe both throughout this presentation. And lastly, cannabis. A lot of studies still use the term marijuana, so when discussing results from these studies, I will use cannabis and marijuana interchangeably. All right, so why is this important? Cannabis is actually the most common illicit substance used during pregnancy. And a 2017 cohort study found that 51% of individuals treated with MAT, either buprenorphine or methadone, also use cannabis. So the objective of my literature review was to analyze the literature related to cannabis use and breastfeeding, as well as the literature related to MAT and breastfeeding in relation to current clinical guidelines and recommendations. So ACOG recommends for general breastfeeding that exclusive breastfeeding for the first 6 months of life as mutually desired by the woman and her infant. So here is a table from my essay. It is very busy, so I apologize, but basically this table shows organizations' recommendations regarding both cannabis use and MAT while breastfeeding. So the first part of this chart is cannabis use, and underlined are important phrases that I want everyone to consider throughout this presentation. So ACOG says harms are not fully known, so we shouldn't use marijuana. CDC says the data on the effects and exposure to the infant through the breast milk data is limited and conflicting, so we don't use it. And then the CDC says that we should take a risk-benefit approach when considering medicinal cannabis. So we should consider risks and benefits to both the infant and the mother. In contrast, the recommendations for breastfeeding and MAT all state that breastfeeding should be encouraged for those women with OUD or breastfeeding individuals with OUD that are stabilized on their buprenorphine or methadone treatment, because transfer of medication through breast milk is minimal and the benefits largely outweigh any theoretical minimal risks. All right. So now I will go through my methods. So here is my Prisma diagram for the search process for cannabis. I included 14 studies for review after the search and selection process. 4 studies include THC transfer to breast milk. 4 studies studied the outcomes of infant motor and cognitive development. 3 studies included safety of cannabis use while breastfeeding, and then 3 studies considered provider practices as outcomes. And because of limited literature available for this topic, my inclusion criteria was basically anything that involved those 4 outcomes studies. I did not exclude based on date of publication, but in regard to provider practices, all studies were from the US because I wanted to consider the legality of both recreational and medicinal marijuana and how these policies affect provider practices. So again, here is my Prisma diagram for my literature search for MAT. And I included 11 studies for review. 6 included studies were on the transfer of buprenorphine and methadone into breast milk. 4 on infant outcomes, including well-being and developmental delays, and then 1 on provider practices. And the inclusion criteria, again, was on those 3 outcomes I listed. And then studies should have also been conducted in the US for provider practices. And then for this, I did exclude based on date of publication. So any studies published prior to the year 2000 were excluded because recommendations regarding buprenorphine had recently changed. So prior to that date, there was very limited data on buprenorphine and only methadone was encouraged while breastfeeding. Right. So here is a table including a breakdown of all 14 studies that were selected for the literature review, including type of study, sample size, sample type, and then the outcome considered. And these are broken down by outcome. However, for the purpose of this presentation, I'm only going to focus on 2 outcomes for the sake of time. So I'm going to be looking at infant development outcomes, including cognitive and motor development, as well as provider practices. So in bold, under infant development, are 3 cohort studies, and 0 out of these 3 studies found significant results between infant exposure to cannabis and motor or cognitive delays. And then the last study was a literature review. And the literature review conducted by Ordine and Kim found conflicting outcomes regarding the risk of exposure to cannabis in breast milk. And they actually included the 2 studies, Astley and Little and Tennis et al. And so they concluded that breastfeeding should be discouraged while using cannabis, or if that was not attainable, that the amount of cannabis consumed should be limited. So 3 qualitative studies were also included on provider practices, and key findings from these studies include that 41% of respondents, provider respondents, recommended continued breastfeeding even if a patient was using cannabis. In contrast, 15% recommended to stop breastfeeding when using cannabis rather than to encourage stopping the cannabis use and then continuing breastfeeding. They just said that they recommended stopping breastfeeding altogether. And lastly, 48% of providers did not respond to individuals' disclosure of cannabis use. And I found that when providers did respond, rather than discussing potential risks of exposure, they use CPS involvement as a deterrent for cannabis use. So they didn't discuss data or studies on why it may be harmful. They just said CPS may be involved if you continue to use cannabis while breastfeeding. All right, so here is my table, including the 11 studies for medication-assisted treatment. So I had 6 studies on both buprenorphine and methadone transfer into breast milk, 4 studies related to infant outcomes, including well-being and development, and then 1 study on provider practices. So again, I'm just going to look at infant development and well-being and provider practices. So again, no studies had significant results. So there was no correlation between exposure to buprenorphine or methadone and adverse infant outcomes. So the first 2 studies were cohort studies again, and the last 2 studies were literature reviews that also found that that use of MAT while breastfeeding should be encouraged. So for provider practices, Clark et al. found that providers serve as a barrier to breastfeeding. So despite breastfeeding being encouraged by clinical recommendations, providers are actually the main reason that individuals with opioid use disorder that are prescribed buprenorphine or methadone do not breastfeed. And the reasons for this include personal bias, lack of training, and inconsistent or lack of institutional policies. So I bring this table to our attention again because of the language that is used regarding clinical guidelines. So you can see there's a lot of inconsistency for cannabis use. And for MAT, the language and recommendations seem to be more consistent. However, what we found is that despite cannabis use being discouraged by these organizations, including ACOG, CDC, and ABM Clinical Protocol number 21, providers still encourage breastfeeding even if the breastfeeding individual uses cannabis. And again, the data shows no statistically significant results that cannabis exposure has an adverse effect on infant development, including cognition and motor development. In contrast, the recommendations encourage breastfeeding for individuals with MAT, with OUD who use MAT. However, providers often discourage this and serve as a barrier for individuals who wish to breastfeed despite being treated with buprenorphine or methadone. And again, the studies have shown that exposure to buprenorphine or methadone through breast milk is minimal, and it has no adverse effect on infant well-being or development. So again, there were a total of 35 studies included in this review. And some important things to consider for the literature on cannabis is that cannabis is not legal in all states. In some states, it is legal for both recreational and medicinal use, and some states it's illegal altogether. And it's also to consider that the two main studies that are cited for recommendations regarding cannabis use in breastfeeding are from 1989 and 1990. And they did not have any significant findings. However, they had findings related to pregnancy and cannabis use. And so those findings are often misconstrued with the findings regarding breastfeeding. And limitations for these studies included outdated literature and very small sample sizes. And some things to consider for MAT is the inconsistency of providers' practices from institution to institution, and even within institutions, personal bias may impact what providers are actually doing. So one study found a way to combat this is to have, rather than following these larger organizational policies, to have each institution have a clear guideline on substance use, each substance use, specifically buprenorphine and methadone, and then educate providers to reduce bias and ensure that all information is up to date, and we're focusing on the safety and well-being of both the breastfeeding parent and the infant. And again, studies were very limited, and studies had very small sample sizes. So to conclude, provider practices and perceived safety of cannabis and MAT are incongruent with current professional guidelines. So more studies need to be conducted on infant exposure and safety for all three of these studies. And then the results from these studies need to be used to modify or enforce current professional guidelines. So there needs to be consistency in the guidelines that we see regarding breastfeeding. All right, so that concludes my presentation, and I wanted to thank Dr. Susan Gross, my advisor and my first reader. She was super helpful in this entire process. I also want to thank Caitlin Cross-Barnett and Linda Stretfield, my advisors at CMS, who helped with the development of this study through their MOM model, the maternal opioid misuse model. I want to thank Dr. Mary Catherine Augustin, who helped me in the later part, especially with my presentation. Thank you for meeting with me yesterday, Mary Catherine. And then I also want to thank the PopFam department, both the faculty, staff, and students. This has been a wonderful 2 years. And lastly, I want to thank my family and friends at home. I could not have done this without them. And here are all of my references.
Great. Thank you so much, Emma. Wonderful job. I can take questions both in the chat and you can unmute yourself. David.
No, go with Mona. And I'll
Oh, okay, Mona. Sorry.
quickly. I prefer the students to go. I'll go later if time permits.
Sounds good. Okay, so Mona, let me read your question. Do you think that sample size could have played a part in not having any statistical findings in these studies? Shout out to Epi.
Yes, I do think that's a possibility. So some of the larger sample sizes are about 136 participants. So specifically with the cohort studies involving infant outcomes, those tended to be the smaller studies, but also I did look into the transfer of THC into breast milk, and those study size sample sizes included like 400 participants. So those did have significant findings, and they did find that the transfer of THC into breast milk was very minimal, and cannabis, THC, and other cannabidols have a low bioavailability. So that was an expected finding, but in terms of infant development outcomes, yes, I definitely think that small sample sizes could have played a part.
Great. Okay, David, you can go now. I'm not seeing any questions in the chat.
Good, thank you. Emma, that was really great, so thoughtfully presented and carefully described. My question is, does this bump up against the issue of smoking and breastfeeding, not cannabis, but smoking and recommendations? Do they overlap, vary, or are they fully considered in terms of recommendation?
Yes, so that's a great question. So actually, smoking tobacco no longer is discouraged while breastfeeding. They find that the benefits of breastfeeding outweigh the risks of smoking, except for co-sleeping individuals, the risk of SIDS is increased. So professional guidelines now say that smoking is okay, and even alcohol use in limited amounts is okay, but cannabis use is not.
Thank you.
Interesting. Okay, I have time for one more question for Emma. All right, it looks like that's it. So Emma, thank you so much. This was really interesting. Congratulations. All right, so our last presenter is Althea Wolfe, and she attended University of Southern California. She received a Bachelor of Arts in Neuroscience, and she minored in Gender Studies. The title of her presentation is called The Impact of Bodily Autonomy Violations on HIV Partner Disclosure, Results from the PLHIV Stigma Index 2.0 in Ukraine. So Althea, whenever you're ready, you can share your screen.
Great, thank you so much, Kristen. Okay, can everyone see my full screen?
Yep.
Lovely, okay, I will get started. So first, I'm going to start with some key definitions as we go forward. First, oblasts are regions in Ukraine. 16 of them were included in the study. PLHIV stands for people living with HIV, and WLHIV stands for women living with HIV, two acronyms I'll use a lot. IDPs are internally displaced persons. That will be a population of significant interest going forward. And then key populations I'll refer to typically are groups who are stigmatized, discriminated against, and otherwise hidden regarding HIV programming and research, but have significant need. So this includes men who have sex with men, sex workers, people who use drugs, and transgender groups typically. And then ART is antiretroviral treatment for HIV/AIDS. Right, so some background and context. So what is the Stigma Index 2.0? So it is a research, it encompasses a lot. There is a standardized survey, the Stigma Index 2.0, and the international partnership, which is composed of UNAIDS, the global network of people living with HIV, and the international community of women living with HIV. They oversee it, they help design protocols, they help conduct interviews, analyze results, and disseminate reports by giving guidance to the in-country teams who are implementing. And the goals of the Stigma Index 2.0 are to improve the evidence base for targeted advocacy, center people living with HIV in every level of research, including research development and staffing, and then focus on women, marginalized groups, and key populations who are otherwise left out of traditional HIV and stigma work. And these are just some of the countries that we have had the privilege to work with, and they are in various stages of the research process. So country context, the Russian invasion and ongoing conflict in Ukraine. This is not key knowledge for the timing of the study. It was conducted in late 2020 in the summer, but it is important for ongoing significance, and the conflict is a large reason why I chose to focus on the areas I did. So some things to remember and some refreshers. The invasion is going in from the east. So the two oblasts in the easternmost border, Donetsk and Luhansk, are in the Donbas region, and that is currently under Russian control. People in these areas are subjected to heightened violence, both by military action and violence from person to person. And supply shortages and destruction of health clinics and other facilities have been very common. Some numbers going forward, there have been over 6 million refugees housed in neighboring countries like Moldova and Poland. 7,700,000 people are newly displaced in Ukraine. And this is in addition to the 1,700,000 who were already displaced as a result of the conflict that has been ongoing since the annexation of Crimea in 2014. So again, this is newly displaced in the last several months. And then over 7,000 total casualties across all oblasts. And then as far as the HIV landscape, 260,000 adults and children living with HIV, 120,000 of these are women, and only 69% of those living with HIV know their status. So the study sample and my hypothesis going into my quantitative analysis. So the Stigma Index implementation was conducted in Ukraine, again in late 2020. There were 2,201 participants in total. And of that, I chose to focus on 1,066 cisgender women living with HIV because they were the population that kept coming up when I was looking at gender-based violence, sexual violence, and partner disclosure, which are my exposures and outcomes of choice. So my proposed hypotheses, so I had several. First was that trauma, fear, anticipated stigma, and shame would all work together as pathways to make women living with HIV less likely to disclose their HIV status to their partner if they had ever experienced bodily autonomy violations. Second, internally displaced people will have higher rates of sexual violence and reproductive coercion than non-displaced women. And then IDPs will have even stronger inverse relationships between these violations and partner disclosure. So more on my exposures, starting with reproductive coercion. So reproductive coercion in this context with women living with HIV encompasses a set of coercive practices and behaviors done by healthcare workers in clinical settings. I know reproductive coercion has other meanings in intimate partner settings, but for this presentation, this is what RC is. And in the Stigma Index 2.0, there are 5 main themes within the questions. So ART pressure, sterilization, counseling, family planning, and delivery methods are all arenas that reproductive coercion plays out in. Sterilization especially has received, I'd say, the most mainstream attention because of legal advocacy. There have been national lawsuits in Namibia, Kenya, Chile, South Africa, and other places that have brought this to the attention of global human rights entities. And some others like abortion pressure and lack of contraceptive options also pop up in other literature. So reproductive coercion and sexual violence were my 2 exposures that I chose to focus on. So the sexual violence indicators, the first was, have you been forced to have sex when you did not want to in the last 12 months? The second, very similar, have you ever been forced to have sex when you did not want to? So the questionnaire had 2 different timing options that I separated and looked at on the binary scale. And for reproductive coercion, it had 2 separate questions that had different time frames, and each had 5 questions that I chose to combine to make into a binary indicator because no single subtype had enough responses to really get a good analysis. So they encompass the 5 different arenas that I had in that model. And for the lifetime reproductive coercion indicator, it was more pregnancy focused. So these 2 indicators can't be directly compared, but they were asked of the same people in the sample. And violence as an exposure, just a word on why I conceptualize these 2 exposures working together and being interactive with disclosure in the same way. I love this quote. I think it really captures violence against women living with HIV. So violence against positive women is an act, structure, or process in which power is exerted in such a way as to cause physical, sexual, psychological, financial, or legal harm to women living with HIV. So violence doesn't just have to be physical or sexual. Violence can encompass all of those coercive behaviors that I named before. So now the outcome was partner disclosure. And partner disclosure in this case was simply a binary indicator. Does your partner know your positive HIV status? It was only asked of people who had indicated that they did currently have a partner. So the results. First, just looking at frequency of the exposures, which was one component of my hypotheses, I did find that displaced women had significantly higher rates of reproductive coercion, both lifetime and within the last 12 months, and sexual violence within the lifetime. Sexual violence in the past year was far lower than the other indicators. I suspect that for displaced women especially, there may have been other factors that would have prevented them from participating in the study. They are more hidden in many ways because of lack of access to HIV treatment and care. But these were the exposure frequencies I found. And then when looking at the logistic regression results, I adjusted based on age and education and found that lifetime sexual violence in the last 12 months, and reproductive coercion in the last 12 months were all significant for the sample as a whole. For sexual violence and in the lifetime and in the last 12 months, it was in the direction that I had predicted. So women were less likely to disclose their HIV status to their partner if they had experienced sexual violence in the past. For reproductive coercion, this was not what I was expecting. The directionality was reversed. They were actually more likely to disclose to their partner. For internally displaced women, the results were completely different, and not in a way that I had predicted. So lifetime reproductive coercion was the only model that I could see with any significance. And the directionality was the way that I had initially predicted for all exposures. So they were less likely to have disclosed their status to their partner if they had ever experienced reproductive coercion. So some discussion points quickly. The sampling strategy and the temporality of the study and of the analysis are definitely limitations. The oblasts included in the study were, they did not include Luhansk or Crimea, they only included Donetsk. And when you're looking at displaced people especially, and when you're looking at these exposures of violence, including areas where violence is more prevalent is going to be so important going forward. And the temporality, so getting specific perpetrator information, understanding when the violence happened in the life course, and also understanding the relationship history of the current partner. Those are all going to be key to understand the more specific mechanisms by which violence and bodily autonomy violations influence partner disclosure. And then as far as future research, I think there is a whole area that is, open with this conflict. It's going to be so important, understanding exactly how displacement, migration patterns, and violence will influence some of these really important factors of HIV prevention. So partner disclosure is important to consider when you're thinking about prevention on the large scale. But I do think that studies going forward also need to have this violence lens. Studies and clinicians need to understand how experiences of violence in the past and how intimate partner dynamics will influence whether women who are newly diagnosed or women who have a new partner will want to disclose. It isn't as simple as encouraging them to disclose. There are very real reasons and very real mechanisms by which women with HIV might not want to disclose their status. And understanding violence, so who is perpetrating and in what context, as the types of violence that these women are exposed to, from the military, both military personnel and wider spread bombings of maternity hospitals and other healthcare clinics have happened in the past few months. Understanding where the violence is coming from will help us better understand how to target counseling and target interventions to help encourage disclosure as a way to be cautious about HIV prevention, but also be sensitive to the needs of these women. Finally, my acknowledgements. I have a lot, so thank you to the International Partnership of the Stigma Index. It's been such a privilege getting to see them work and to see how they really champion advocacy for people living with HIV across the world. Thanks to the Keep Populations team who has helped me so much. My first reader and PI, Dr. Steph Baral, who helped me take this mishmash of interesting ideas and make them into a real analysis. To my second reader and advisor, Dr. Ann Burke, thank you for all of your support over the last 2 years. My family, my boyfriend Jack, who has kept me alive and sane, even from DC, and to my cohort, who I can't believe I had the privilege of meeting you during COVID. I went into this not knowing if I would meet anyone or have any support at all. And yeah, this has been an amazing 2 years.
Great, thank you so much. Wonderful presentation. So I will open it up and first off to students. So I see Nikita, your hand is raised first.
Hi, Althea. First of all, congratulations. I'm so impressed by you. This was incredible to listen to. My question is, why did you choose a survey on stigma to look at violence and disclosure measures?
Yeah, that is such a great question. And it's something that I really grappled with this entire time. I think at first blush, it might seem like it isn't conducive to a good analysis, or it isn't really the type of questions that we need to be asking about violence, but reproductive coercion especially is a form of enacted stigma and discrimination, because these coercive behaviors are only being done because of women and other people who can be pregnant, who can use contraceptives because of their HIV status. And understanding it through that lens, I think, is a really important complement to legal advocacy and other work going on. So I think that more research is definitely needed in the violence and intimate partner violence spheres, but I do think that Stigma was a really wonderful place to start and to get a broader idea of what's going on.
Great, thank you. Other questions? Haley is asking in the chat, how widely studied is RC in the Ukraine, reproductive coercion?
So it is barely studied in the Ukraine. I think reproductive coercion broadly among women living with HIV is chronically understudied. The articles that do exist are primarily reviews of already existing literature and studies on prevalence, on incidence, on risk factors are really far and few between. Many areas have started this research process after a court case. So that's why in Latin America, in Namibia and South Africa, there are some studies that get a better idea of prevalence and risk factors. In Ukraine, this is really the only source of reproductive coercion information that I could find. But clearly it is happening. This study, the sampling, it is getting a good idea at how many women living with HIV might be, at risk for this or have already experienced it. So a lot of the research is also focused on people who use drugs, who are a key population for Eastern Europe, but I think that research can absolutely be kind of broadened to include other violence measures and reproductive coercion in conjunction with drug use.
Mm-hmm. Wonderful. Thank you so much. We are out of time, unfortunately, but Althea, this was a great presentation. I really want to thank you for it. And I want to thank all of the presenters again today. It was a fabulous day. And we have one more session tomorrow, our final session at noon. So we hope to see everyone back tomorrow. And on that note, I wish you all well and have a great rest of your Tuesday. Bye, everyone.